Alright, I guess this is lecture 3 or 4 for this lab review, and we have the cerebral cortex and organization. I found this lecture to not be super well organized, same with lecture 82, unfortunately. We're going to do our best. I feel like I had to supplement it quite a bit. So we have cortex organization. Basically, we're looking at the organization of the cortex based on cell layers. And so we have 3 different categories. We have archicortex, which has 3 cell layers. Example would be the hippocampus, would be like the paleocortex, which has 3 to 5 layers, which is the olfactory complex is an example of that. And then the important one is the neocortex, which has 6 layers, and this is most of the cerebral cortex. So we're going to talk about the neocortex today because this is most of the cerebral cortex. Overall, it's going to have 6 layers as shown here. And we don't need to know them, I believe, in too much detail, but we have a couple different cell types, and then understanding more or less where exactly they're going to be sending their axons, etc. So first off, neocortex, as we said, 6 layers. We have the pyramidal cells, and these are these sort of cone-shaped ones. They have this like apical dendrite that they send up towards the pia mater, in the direction of the pia mater, not that it necessarily reaches it. And then you have these basal dendrites that spread outwards laterally from the base of the cell, and it's going to project its axons towards other cortex or subcortical sites. These pyramidal cells are located in the lower levels, so 3, 5, and 6. All right, so 3, 5, and 6, right? So you see the pyramidal cells right there. Then we have stellate, aka granular cells. They have these sort of roundish bodies, and they're common in layers 2 and 4. They radiate their dendrites sort of in all directions. They're called intrinsic, or another word for that is interneurons, and they project from one layer of cortex to axons from one layer of cortex to the next, just connecting them. And as we said, 2 and 4 are stellate or granule cells. All right, so then fusiform cells are our final one. These are spindle-shaped. We weren't told anything other than that. They were located in 1 and 4, but I think takeaway for you, hopefully, and for me, is that pyramidal cells located further down, and then our stellate cells are interneuron, and they're located a little higher up. So 2 and 4 versus 3, 5, and 6 for pyramidal. And then fusiform are in the very top or very bottom cell layer. Again, this is neocortex, which is what most of the cerebral cortex is. Then we were told about Brodmann's areas, and basically you can categorize the cortex based on cytoarchitecture, which is the number of layers and cell types that there are, and it just so happens that Brodmann's areas also correlate very well with function. So we have this like nice diagram with all of the different numbers, and it's kind of nice to know, pretty, but I'm under the impression we don't need to memorize that. And then we were given this, which is just showing activity in different cortex regions during particular tasks, and so you can, sort of map this out, right? For walking, primary motor cortex would be like located right there. Hearing might be like temporal lobe, seeing occipital lobe, thinking prefrontal lobe of the frontal cortex. Remembering sounds a lot like the limbic system, right? So not too bad, but just more of what we know. All right, so then we had different connections, and so basically we can go to a couple of areas. We can go from cortex to cortex, and we'd call that cortical afferent fibers. If you're going ipsilaterally, meaning staying on the hemisphere side, we'd call those association fibers. If you're going contralaterally, those would be called commissural fibers, contralaterally to the other hemisphere of the cerebral cortex, right? And so the afferent out or input fibers generally end in layers 1, 2, and 3. So input is coming in these 3 layers generally of the neocortex. That's where it's getting received, 1, 2, and 3. And notice we have pyramidal cells there. These small pyramidal cells, and sort of like medium pyramidal cells are taking the afferents. And then we have thalamus to cortex, thalamocortical cells. And then we're supposed to say these are stimulatory generally. Thalamicocortical cells, afferent fibers are coming in from specific thalamus nuclei. They're also stimulatory. They generally end in layer 4. All right, so thalamus layer 4. And then we have subcortical afferents from different modulary centers, which we have listed to us. I don't think we've ever had too much detail in these other than midbrain, but we were told in lecture that inputs from modulary centers are going to go to all the different layers. All right, but cortex to cortex, 1, 2, or 3. Thalamus to cortex is 4. Again, this is input afferent fibers. All right, so not too bad, hopefully. What if we want to send out fibers, outgoing from cortex to other cortex, or cortex to thalamus, or cortex just to brainstem, something like that? They're generally excitatory synapses using glutamate or aspartate. Cortex would be cortical, and you have axons of layers 2 and 3. All right, so 2 and 3, cortical, outgoing. It's from these small pyramidal cells and medium pyramidal cells, and again, it goes to other cortex neurons. Then you have cortical fugal axons, fugal meaning just leaving cortex. And so these are from the large pyramidal cells in layer 5. And this is going to go fugal, so brainstem or spinal cord, and those targets are pons, right, red nucleus, basal ganglia, and all layer nuclei. So brainstem, midbrain, pons, medulla, spinal cord, and then you have cortical thalamic axons. That's going to be layer 6. And then finally, we already kind of touched on this, but types of axonal fiber bundles. We said if you're going from ipsilateral cortex, this is going to be association fibers. We have 2 different types. We have from one gyrus to an adjacent gyrus called U fibers, and then if they're not between adjacent gyri, we would call them sort of long fibers. And we're given a couple of examples. We have superior longitudinal folliculus, which you can see here. And it's going from the frontal lobe to the occipital parietal lobe. This is going to be dealing with eye movements. Then you have the arcuate fasciculus from the superior temporal, from frontal, to posterior superior temporal. And this is, of course, actually going to be Broca's to Wernicke's right there. Then we have eusinate fasciculus, and this is going to go from anterior temporal lobe to frontal lobe for limbic function. The eusinate is dealing with limbic function. And then you have cingulum, which connects the cingulus gyrus to parahippocampal gyrus and septal. And this is going to be dealing with limbic function. You should know that based on cingulum, cingulate gyrus. All right. tons to memorize. I wish I spoke full on this. So anyways, we have the commissural fibers are from cortex to contralateral hemispheric cortex, and you have basically generally projecting from homologous areas to homologous areas. So right, you think this area of the cortex is dealing with the face, let's project to the other area of the cortex is dealing with the face. The only two exceptions are areas controlling the eyes and hands, but these commissural fibers are connecting homologous areas. The two big commissural fibers, we have the corpus callosum, which you can see here. And so we have body, spondylium, genu, and then we have the anterior commissure, which interconnects the rostral parts of all temporal lobes and connects both olfactory bulbs. Remember, rostral means nostril, so towards the front of the face, towards the face of the temporal lobes, anterior commissure. All right, and then finally we have projection fibers, and so we had mentioned we have commissure is from one half of the hemisphere to the other half, or to the other hemisphere. Association are within the same hemisphere, and then projection fibers are, hey, let's project to the brainstem. So going from cortex to brainstem, we weren't given any other information other than that's just what they are, projection fibers, leaving the cerebral cortex. All right, so then we were given some information on the sensory homunculus, and we have the motor homunculus. So we're familiar with this, the primary motor cortex, primary sensory cortex, and basically we know that they map neurons to different regions of the body, and you can follow it. Like this region is lower extremity to arm, then you get face, and so really the same thing applies with the primary motor cortex and the primary sensory cortex regions. And we were told though this mapping can change with injury. If you have a lost limb, basically say like this region's lost, and then this adjacent region is going to say, hey, I'm going to use your neurons for my trunk region instead of the hip region. All right, and so the other thing that can happen, so that's in the case of like a lost limb, if you have just like regular damage, you can have other areas sort of take up the function, right? So if your limb still exists, but you've damaged the cortex that is associated with that limb, you can have adjacent areas sort of take up that function. And then reversible damage, you have basically some damage to an area, and then it will eventually heal and return to like a normal size. All right, we have frontal lobe itself. If you were to just look at different areas of the cortex, frontal lobe is this entire region right here, and this I feel like was very poorly done in the notes. Very unfortunate, but we have the primary motor cortex, and this can have our motor homunculus. If you have lesion here, then you're going to have hypotonia, right, floppy arm. Then we have the premotor cortex, that's the second major region, and this helps with movement planning. If you have a lesion there, you have apraxia, so difficulty making certain movements. Then the final area is the prefrontal cortex, and the general function of the prefrontal cortex, right, this whole region is frontal cortex, right, but this is prefrontal cortex. Prefrontal cortex is dealing with executive functions, so judgment, evaluation, goal setting, motivation, planning, and then you have different parts of the prefrontal cortex. And I thought this was very confusing in the notes, but these are the different parts of the prefrontal cortex. We have the orbital frontal part, which is in the very front, and we can see that here, and this is going to be the decision-making part. Then we have the dorsal lateral part right here, and this is going to be associated with executive functioning, so goal setting, presumably, planning, potentially, and then superior to that, we have the frontal field, and so like frontal field, this is going to help control eye movements. So if you stimulate it, it will move both eyes to opposite sides. And then on this ventral lateral area right here, the prefrontal cortex, you have Broca's area, which is going to be dealing with the production of speech. So motor control of speech, Broca, as we've always learned, like boca Spanish for mouth. And this is found in the pars triangularis, which is area 45, and then the pars opercularis, area 44, but this is the ventral lateral part of the prefrontal cortex. Lesion to that will give us Broca's aphasia, difficulty expressing words despite understanding them. And then just a quick note on evaluating the prefrontal cortex, you have this thing called the Wisconsin card sort, which is you can have a patient match cards based on color, shape, or number, and they should be able to do that if their prefrontal cortex is functioning fine. And then frontal cortex involvement of the motor cortex, right? Motor versus premotor cortex. So motor cortex movement without planning. If you have a movement that is planned and executed, that would involve both the motor cortex and the premotor cortex. And then if you have planned movement but never executed it, that would be our premotor only. All right, so that was quite a lot. And then we have more of the cerebral cortex. So we have the parietal lobe, of course, and we can see the parietal lobe here. The nice thing is we don't have too much here other than there's really three parts. We're familiar with the primary sensory cortex, which is going to give us our sensory homunculus. Lesion to this is going to cause loss of sensation on the opposite side of the body, pins and needle sensation, and might have difficulty being able to distinguish type of sensory input if you do get it. Then we have behind that, this is the posterior lobe, and the posterior lobe is made up of two lobes itself. You have the superior parietal lobe, and then you have the inferior parietal lobe. The superior parietal lobe, if you damage it, you get asteronausea, which is if you were to grasp an object in your hand, you couldn't recognize it based on the shape and the texture. Loss of hand-eye coordination, optic ataxia. Then you have the inferior parietal lobe right here, and if you have damage to that on the non-dominant hemisphere, you're going to have contralateral neglect. So we were told that, what does that mean? You won't shave or apply makeup to the side of your face that is opposite to the lesion side. So for instance, a patient normally, somebody who's left-sided dominant, since we're dealing with a non-dominant, on the non-dominant hemisphere, where the lesion is, you would have the deficit on the left side. It's a little confusing. So if you have the lesion on the right side, aka the non-dominant hemisphere, your lesion is going to be on the left side for the inferior parietal lobe. Right? Inferior parietal lobe giving us contralateral neglect. If you're on the dominant hemisphere, which again is typically the left side, a lesion is going to cause Gertzmann syndrome. You'll have difficulty reading, writing problems, math issues. So alexia is difficulty reading, agraphia is difficulty writing, acalcula is math issues, calculus, right? Left-right problems, and then nomia is difficulty naming common objects, right? But inferior parietal lobe, if you have it on the non-dominant side, or if the lesion's on the non-dominant side, then you have contralateral neglect. If it's on the dominant side, then you're going to have Gertzmann syndrome, or you have difficulty reading, writing, doing math, naming common objects. All right, so that was parietal lobe. Then we have occipital lobe. Occipital lobe knows back here. Of course, we also know occipital lobe has to do with the eyes. So it's processing visual information. We have area 17, area 18, and area 19. Area 17 is the primary visual cortex, the very back, the very caudal part, and you have the striate cortex there as well as an area called V1. A lesion to the area 17, which includes all of these regions, is going to cause something. Small changes in the small area of vision, you can get blindness, so scotoma, and you have blindness in part of your vision. Then visual association cortex is just the rest of it, 18, 19, V2, V3 is in this region. All right, temporal lobe is the last one we haven't covered, so here's temporal lobe. I think I skipped it, accidentally went out order well. Temporal lobe is going to be dealing with auditory processing, memory retrieval, formation, language comprehension, motion regulation. This was the section in our notes I thought was like possibly the worst done. So we see, this is the typical view we're used to seeing for the temporal lobe. This is the superior temporal gyrus, middle temporal gyrus, inferior temporal gyrus, and the superior temporal gyrus, if you were to sort of peel it back, you can see that we have Wernicke's area right here. And specifically, you have it on the dominant hemisphere. On the non-dominant hemisphere, you're going to have just an area that perceives the rhythm and emotion of speech. And then, as we said, in addition to superior temporal gyrus, you have middle temporal and then inferior temporal. Inferior wraps around to the bottom of the temporal lobe. And so on the inferior surface of the temporal lobe, you have the inferior temporal gyrus. You have the occipital temporal gyrus, which is also called the fusiform gyrus. And the reason it's called occipital temporal is because it actually extends from the temporal lobe into the occipital lobe. But we also call it fusiform gyrus. I'm not sure why, mostly. Who knows? Maybe to confuse us. Hopefully not. But it does color vision, face recognition, perceived facial expressions. And so that's going to be located right here and on the inferior side. Then you have the parahippocampal gyrus on the temporal lobe, and you can see that right here. And at the very end of that, you have the uncus, and that's, again, the end of the parahippocampal gyrus. The uncus does olfactory smell interpretation, right? And then the rest of the parahippocampal gyrus is doing limbic function, memory, and emotion. All right, and then finally, deep inside the temporal lobe, you also have the hippocampus, so you can see that here. And that is going to also be adjacent to the amygdala. All right, but that's going to be part of the sort of emotion memory processing. All right, finally we have brain dominance. Just a quick thing. So dominant hemisphere is usually the left, but not always. It deals with language, speech, and writing. You can remember this because dominant, you think Wernicke, and you think Wernicke. So if you are damaging Wernicke's area, you can have a hard time understanding speech. It also does logical thinking, calculation. Then we have the non-dominant side, which is usually right. This is spatial orientation, facial recognition, and creativity. All right, so that's it. Then we were given just a huge mess of terms, and so I guess we'll try and read them. But separating things that are dominant versus non-dominant lesions. So Broca's area, if you damage that, you're going to have basically issues with motor or non-fluent dysphagia, so difficulty talking. So usually on the left hemisphere. If you damage Wernicke's area, you're going to have a difficulty understanding speech. Again, this is unique to the dominant hemisphere. And if you were to, say, damage the equivalent of Broca's area on the non-dominant side, so forming speech tone and inflection versus just like saying words of Broca's area, so tone and inflection if you hurt the non-dominant side. And then for Wernicke's, which is language understanding, if you hurt the non-dominant side, you're going to have a hard time interpreting tone and inflection. Okay, and then you have either hemisphere, and for either hemisphere, we have sort of hurting premotor cortex, premotor cortex area, apraxia, primary motor, hypotonia, floppiness, right? Premotor and primary motor, upper motor neuron syndrome, right? Spasticity, frontal eye field destruction, transient deviation of the eyes towards lesion. If you have an irritation of the frontal eye field of the prefrontal cortex, deviation of the eyes opposite side, and then superior parietal lobe, which is astronausea, can't recognize objects by hand, and then inferior parietal lobe, we said was on the dominant side. Gertzmann syndrome, which is difficulty calculating, reading, writing overall. And if you hurt the inferior parietal lobe on the non-dominant side, you get the contralateral neglect, which is when if your non-dominant side is the right hemisphere, then the left side of your face, you're not going to shave. Okay, so then we have finally different types of brain injury. We have stroke, which is most common type of death. You have ischemic, right? So thrombosis, embolism, hemorrhagic, right? It can be caused by an aneurysm, so weakening and rupture of the arteries, arterial venous malformations. But basically, stroke is going to be your brain is dying because they're not going to get the nutrients, specifically oxygen. And then different causes that can do that, right? So just a blockage or blood vessel rupture. Traumatic brain injury, contusive, direct impact, penetrating bullets, diffuse axonal, so rotation, abusive, head injury, shaken baby, blast injuries, tumors, surgeries, brain abscess, infection. And then anoxia, just lack of oxygen to the brain as a result of maybe strangulation. Deficits, we were told that A means total loss, and then dis means difficulty. So apraxia is difficulty carrying out skilled tasks. Agnosia, difficulty recognizing objects. Aphasia, difficulty understanding languages. Apulia, difficulty initiating movement. Disconnection syndrome, disconnecting centers. Based on brain as a group centers for processing information which are linked by connections. Disconnecting centers may have the symptoms of destroying those centers. Okay. Alexia, difficulty reading. Calculus, math. Agraphia, hard time writing. Anomia, difficulty coming up with names. And then memory, learning and balance deficits. All right, so that was it for that lecture. We just have blood supply to go over, and then we're done with lab 10 material. All right, this is the final lecture review for lab 10. Blood supply to higher order centers. This is lecture 82. And so this basically is going to be dealing with the circle of Willis, and that's this guy right here. We're going to be focused on the anterior cerebral artery, middle cerebral artery, and posterior cerebral artery, and that's pretty much the basics for this entire lecture. And so here we have what the anterior cerebral artery does, here we have what the middle cerebral artery does, and here's what we have what the posterior cerebral artery does. So at that point you can almost stop, but we are going to go for completion here. So we have different injuries, just sort of generally. So we have, this is the epidural, and you see a nice lens shape, and this is between the skull and the dura mater. Then we have subdural, and so you have sort of a sickle-shaped one, and I think maybe a sickle is like this, right? So sickle-shaped versus and a little bit longer than the sort of bulging out that you see with the epidural. So subdural, and it's between the dura mater and arachnoid mater, and it's due to damage of bridging vein. Then you have subarachnoid, which is blood below the arachnoid mater, and a little bit hard to tell here, but we have thunderclap headache is the sign, and then intraparenchymal bleed, right? Remember, parenchyma is like the functional cells of an organ, so that's just blood inside of the brain tissue. There might be an example, but overall treatment for epidural between the skull and the dura mater, subdural between dura mater and arachnoid mater, subarachnoid below the arachnoid mater, and then intraparenchymal is to reduce intracranial pressure, get that blood out of there. All right, then we were told about watershed infarcts, and so this is basically a type of stroke, and stroke again is for whatever reason loss of like blood flow to an area. It's limited loss, and so you get sort of brain ischemia, so loss of oxygen, and your brain cells die. And so watershed infarcts are a type of brain injury that causes a global loss of blood flow, but it's definitely regional in the sense that you're going to have different areas. So we have cortical watershed, which is damage to the middle cerebral artery, anterior cerebral artery, or posterior cerebral artery. And again, it's weird that this is the beginning of a lecture because I don't know why they would do that. But if this is what middle supplies, this is what anterior supplies. If you have damage here, then there's supposed to be sort of like a little bit of overlap between supply and regions in between, right? So if you have damage to middle, anterior, or posterior, what you find with the watershed infarcts is you have this. So if you have a stroke that damages anterior cerebral artery, middle cerebral artery, then you're going to have these zones that are dying. So cortical watershed, you have this wedge-shaped zone in the front, caudally, if it's between anterior and middle cerebral, and then posteriorly, or excuse me, caudally, rostral, caudally towards the back of the brain, if it's between middle and posterior cerebral artery, you have this wedge shape that would also be cortical watershed. But it's stroke, brain ischemia, it's just the pattern that these damages to anterior cerebral artery, middle cerebral artery will cause. It looks wedge-shaped. Okay, then you have internal watershed stroke, and so this is going to be damage to the middle cerebral artery or the lenticulostriate artery, and it's going to cause this damage right here. Lenticulostriate we'll talk about a little bit later. I'm sure I have a good image of it, but it supplies basal ganglia, which we know is in this region, right? So if you think basal ganglia, it's in this region, and that thing gets choked, then you're going to have ischemia that looks kind of like this, and it looks kind of oval-shaped, right? We were also told that, so this is internal watershed, it looks rosemary-like, or rosary-like. I'm not sure I see that. I honestly feel like the word rosary is a little weird. This is someone who's Catholic, what? This is bizarre. Anyways, if you have bilateral internal watershed, which this person looks like it might have, you get something called man and barrel, and this is weak upper limb and lower extremity issues, and again, this is going to be dealing with the middle cerebral artery and the lateral lenticulostriate artery, and you think middle because you're like, hey, middle does this region right here, okay? But again, this all goes back to the circle of Willis, and we have middle cerebral artery, anterior cerebral artery, and they're technically coming off of internal carotid artery right there. Okay, so blood supply, we're just going to look at different regions. We have blood supply to the basal ganglia, and so here's our friends, the basal ganglia. We have different parts of it, the prumen and the caudate, and then we also have substantia nigra and global pallidus more medially, but the overall blood supply is going to be from the anterior cerebral artery, and right here, and the posterior cerebral artery, which is located right here. And so the internal carotid artery is going to actually branch and give us the anterior cerebral artery, but we have a more direct branch from the internal that's going to give us supply to the globus pallidus, right? If you have blockage to basal ganglia, you get Parkinson's-like syndromes, tremor instability. If you have loss of the subthalamic nucleus, you get hemibolismus, which is flailing of the limbs, right? But internal carotid, coming up here, a branch of that's going to supply, you can see branch off that to global pallidus, and then anterior cerebral is going to get our caudate right there, and a little bit of our prumen. Right. All right, so then we have blood supply to the hypothalamus, and we know the hypothalamus is hypo to the thalamus. Here's the thalamus, here's the hypothalamus, and this is going to have anterior hypothalamus is going to be supplied by the anterior cerebral artery and the anterior communicating artery, and so here's the anterior cerebral, here's the anterior communicating artery, and then posterior thalamus is going to be supplied by posterior cerebral and posterior communicating artery. So let's just take a look real quickly at the software. I apologize, it's going to take a minute to do, but let's see, we got our library here. Oh, no, not that one. This one right here. All right, so here we go, and we have our nice circle of Willis. Maybe you can recognize it. We have the basilar artery right here in the center. Come on, click on please. Oh, there we go. All right, basilar artery right there in the center. Then we have the posterior cerebral artery. Look at that, it's going posteriorly. Nice. Then we have, right, let's see, right here, internal carotid. We know that internal carotid is going to branch and give us two branches. Anterior cerebral, we love it, and then middle cerebral, right? And so middle cerebral and anterior cerebral and the posterior cerebral arteries are three arteries that we care about pretty much for this entire lecture, because it's going to do the heavy lifting in terms of all of their branches are going to supply all of the brain. All right, but anterior hypothalamus is going to give us, be done by anterior cerebral, posterior hypothalamus, posterior cerebral. All right, but again, where are we starting with our basics? We're starting with posterior cerebral, posterior part of the cerebellum, anterior cerebral, anterior part of the cerebellum, we love it, and then middle cerebral, we got some temporal lobe, we got a little bit of parietal lobe, and we got a little bit of frontal lobe as well. All right, then we have posterior part of the brain. Well, you guessed it. It is posterior cerebral artery. We love it. And then we have thalamus. So thalamus we already talked about previously, but we have our different branches off the posterior cerebral artery are giving us the thalamus blood supply, and here they are labeled. But I think all you need to remember is that issue to the thalamus, you're going to get those sort of mimicking strokes, right? Which is it's not good, but they can look like damage to other regions. Why? Because the thalamus dying, that's not good. That's our relay station right there. All right, so blood supply to posterior and inferior cortex. Well, we already talked a little bit about posterior brain, but posterior and inferior cerebral cortex supplied by posterior cerebral artery. Right there, woo. All right, and right here as well, right there, and it's coming off our friend the basilar artery. We love it. All right, we're told blockage of the posterior cerebral artery causes contralateral hemianopsia, and hemianopsia. One second. Hemianopsia, which is partial loss of vision in half of their visual field. Makes sense, right? We have occipital lobe back there, and then moving up, we have interior brain blood supply. So posterior was posterior cerebral artery, interior, you can betcha, is anterior cerebral artery, which is a branch of the internal carotid, supplies the medial cortex, and then the medial cerebral artery is going to supply most of the lateral cortex. And so here's kind of the breakdown of the interior sort of rostral brain. We have medial artery right there, anterior cerebral artery right there, and then here's a little bit of posterior cerebral artery deep branch, and then we got some more posterior cerebral artery. This is a very good cross-section, middle cerebral artery right there, okay? So overall, again, those come from our friend the circle of Willis. The internal carotid artery gives rise to middle cerebral and anterior cerebral is inner part right there. All right, so the middle cerebral is doing a whole bunch of the heavy lifting, right? It actually has 4 branches, M1, M2, M3, and M4. Here's just a reminder, rostral means nostril, not really, but towards the front, superior or dorsal, and then inferior ventral, and then caudal posterior. But lateral cortex supplied by the middle cerebral artery, which we see right here. We have different branches, but it's a continuation of internal carotid, and it passes laterally and enters the lateral fissure of Sylvius between the temporal lobe and the insula, and the lateral branches emerge from this lateral fissure and course downward over the temporal lobe. Medial go upwards, distribute over the surface of the cerebral hemisphere. So more on that. Here we have this sort of lateral fissure right here between our temporal and parietal lobe, and then we have different branches. Here we have M1, then we have M2, M3, and M4, and basically middle cerebral artery is the most common site of stroke, and you have malignant middle cerebral artery stroke would be in any of these 4 regions, M1 through M4. But more on sort of the damage just to different branches. M1 branch, again, we see right here. And so you will get contralateral motor and sensory loss, right? So M1 branch is going to give us hemianopsia, right? And that is half your visual field loss. Head and eyes will move towards lesion, cognitive deficits, aphasia, can't understand or express speech, damage to the lateral lenticulostriate artery, which is a branch of M1, is called the artery of stroke or Charcot's artery. It supplies the basal ganglia and the posterior limb of the internal capsule. And this is going to cause hemiparesis, which is paralysis on one side, dysarthria, which is a speech disorder and abnormal movements. And then M2, basically, with loss of blood supply, there's going to be deficits in the face and the arms, transient head and eye deviation, and then hemianopsia, severe cognitive defects, or less severe cognitive defects than M1, and loss of blood supply to the the frontal eye field, EFE, and optic radiation. So not good, but M2, contralateral arm and face deficits. M3, you have right here, and so you have these leptomeningeal arteries, and if you have damage to them, you're going to have Lunicar syndromes, which is not defined for us, so let's find out what that is. Lunicar syndromes. And type stroke, and it's basically sudden weakness, paralysis, almost out of body, sensory loss, clumsiness, and coordination. All right, so not super helpful. And then M4, those are terminal branches supplying the cortex, and it depends on the position of where they are messed up. All right, so then just final thing is medial cortex. So medial cortex supplied by the anterior cerebral artery. So medial cortex is right here, and you can sort of trace the path upwards. This is rostral, this is caudal, towards the back of the brain. Enters longitudinal fissure, passes upwards on medial surface of the cerebellum. And yeah, just no medial cerebral cortex supplied by the anterior cerebral artery. Blockage due, it's going to cause weakness in the lower limb, and yeah, inclusion of the orbital branches are going to result in ambulia, which is lack of lower indecision, as well as agitation. All right, finally, internal capsule is supplied by the medial striate artery, and then the lateral lenticulostriate from the medial cerebral artery. Again, this is artery of stroke. Bet we're gonna have a question on that. And yeah, so that's about it. Final thing is just venous return, and nice thing is it's pretty straightforward. You just have superficial and deep veins, which drain to the sinuses and drain into the external jugular, and you're done. If you have blockage of a vein, you're gonna get an enlargement upstream of it, and you might have bleeding occur, right? So if you have blockage, then it can't drain, and they swell. And then we have just, basically, you need to know that the veins drain into the sinuses, into the internal jugular. So what are the main sinuses? Well, we have the superior sagittal sinus, we have the inferior sagittal sinus, we have the straight sinus that the inferior sagittal connects to, then we have the transverse sinus. Transverse will drain into sigmoid, sigmoid goes into internal jugular overall. The straight, transverse, and superior sagittal sinuses will meet at the confluence of sinuses right here. Then you also have something called the cavernous sinus, which is located right here. That's going to drain into the internal jugular by way of the superior and inferior petrosal sinus. So here's cavernous sinus, it drains into the superior petrosal sinus, inferior petrosal sinus, gets into the transverse sinus, and then into the sigmoid sinus, and then sigmoid will go into internal jugular. But it's important to note this cavernous sinus right here has structures inside of it, which is a little bit strange. So we have the internal carotid artery inside this cavernous sinus, which the cavernous sinus is full of blood itself, right? Just venous blood. And then you have cranial nerve 3, cranial nerve 4, cranial nerve 6, Duson's, and then you have the maxillary nerve in this as well. All right, so that is it, and good job. That was painful, I can say. And I hope you guys aren't stressing too much. We'll get through it. All right, bye guys.